who are member of our association, and many of them are even not the members. Still, we want to do a lot of scientific activities. We know that this time International Diabetic Federation, under the leadership of Professor Dr. Peter Swords, was very, very grand, successful meeting. It was in Bangkok, Thailand. And we thought of that many of the doctors who have attended, but many of them who could not attend. And it's always true that many of them will not be able to come to meeting physically. So we thought that we should have some learnings from International Diabetic Federation, and that what we can do with the help of webinar, online meeting. So I'm thanking our board, particularly our president, that we thought of that we should do a meeting. I'm very, very thankful to Dr. Peter Swords, who had agreed to be the chief guest and to inaugurate this webinar. So now, without wasting much time, now I request Dr. Abdul Bashir, who will be chairing, he will be introducing Professor Peter Swords, and he will be making first remarks for this DSG webinar, and then he will be inviting Professor Peter, and then followed by the talk of three important speakers who will be talking, and later then we are going to have a very important panel discussion, and that panel discussion is on post-meal hyperglycemia. This is a real challenge of Asian people. It's not a challenge for Western or European or Caucasian. It is because of our high carb intake. So we will be having a panel discussion after three important topics. So now I request Dr. Abdul Bashir to start his opening remarks. Over to Dr. Bashir sir.
Thank you, Banshi. Mr. President, Professor Peter Shawat, other faculty colleagues, participants, Diabetes in Asia Study Group Board, it is my pleasure and honor to welcome you all for this important two-day session with the theme of translating IDF 2025 highlights for Asia. I am proud to say that Diabetes in Asia Study Group is having tremendous support of bodies like IDF, ADA, EASD, and other associations, and therefore it is progressing leaps and bounds. Just to remind you that Asia is the main hub of the global burden of diabetes. Hence, with low-income countries, resource constraint, high morbidities and high mortalities, it is very important that Diabetes in Asia Study Group is able to arrange such programs, webinars, as highlighted already by my colleague Banshi Sabu. We are looking forward for these 2 days for excellent deliberations by very highly esteemed faculty, a rich faculty. And for today's theme, it is the glycemic control issues pertaining to Asia. And I now request Professor Peter Shavas, who is our friend, colleague. We have known each other, and the IDF people and colleagues have known him for years. And now under his presidentship, with his support and tremendous support and energy he bears, I request him to give us formal speech as a chief guest before we start the proceedings. Over to you, Peter. Thank you.
Thank you.
Yeah, dear Banshi and dear Abdul, I must say it's a great honor for me to be here today, because to make it very short, the true leadership in diabetes care globally is not with the people administrating diabetes care, is not with the president, it's with all of you who are seeing diabetes patients on day-by-day basis. It's with all of you being in the region and doing every day multiple steps to improve the quality of diabetes care. So I would like to give it back. It's a big, big thank you very much to you for all this activity, all this enthusiasm, all this passion to improve the quality of diabetes care. So thank you very much to you, and thank you for doing this webinar today, because as Professor Abdul Basit already has said, and I know that Banshi don't like this term to say the capital of diabetes is Southeast Asia. And what does this mean? You have a much earlier onset of diabetes. Banshi likes to say the slim fat Indian. I apologize for using this term, but it's actually the slim fat Southeast Asian. And this is a big challenge in terms of pathophysiology, in terms of assessing the people, in terms of developing the right treatment and right diagnostic, and in understanding the pathophysiology. So what we will see in the future is an increase in morbidity and early mortality of those people. So we need science. We need to study this to better understand this disease, to develop preventive and better treatment strategy. And who is better than the Diabetes in Asia study group, who is exactly doing this, focusing on better understanding, earlier diagnosis, earlier prevention, and better treatment for those people living with diabetes. So a second thank you very much to you today for doing this webinar, and a welcome from my side as president of the International Diabetes Federation. 6 weeks ago, we had a very, very good meeting in Bangkok, where the people, I think, have felt there is a new spirit of IDF being fully dedicated to address the need of people living with diabetes. And I truly believe that people with diabetes, especially in the capital of diabetes in Southeast Asia, they deserve a better life because they have the right to have the same accessibility and availability of diabetes care in their environment. And we are far away from this. The WHO has released the combat goals, and they say that 100% of people with type 1 diabetes should have access to affordable and accessible insulin. And I must say, we are still far away from reaching these goals, but 2030, this goal is set. And there's not another option than walking together, not only talking together, but walking together with all this big organization. And one step what IDF was doing is a new guideline, how to diagnose and how to treat and prevent type 2 diabetes, having in mind that the resources and that the environment is very different in Southeast Asia compared to Europe and North America. So this guideline highlights also using the same evidence, but translating into a basic kind of diabetes care. There is a new diabetes atlas highlighting nearly 600 million people living with diabetes worldwide. 80%, and probably it's 85% of them live in Southeast Asia. So in your environment, in your region. So if IDF wants to have an impact on the quality of diabetes care, it has to have this in this region. And this is where the Diabetes in Asia study group is a key performer for me in helping to better understand the environment and to develop better strategy in the region. Finally, I invite you to keep contact, to stay connected, to follow what the International Diabetes Federation is doing. Actually, I want to win you to build a community of healthcare professionals, of scientists, of people living with diabetes who are passionate to act to improve the quality of diabetes care. So there is a lot you can find in social media. And if you have your smartphone in your hand, you can scan this code. This is a WhatsApp channel, which I'm doing myself as president of IDF. And I would love you to find you there, to stay connected with you, to exchange ideas, to better understand how to improve the quality of diabetes care worldwide. So coming back to this picture, every face you see here is a person living with diabetes, and our activity should put a smile on these faces of people living with diabetes. And I'm very much thankful to the leadership of DASG, the Diabetes in Asia Study Group, for taking this leadership, summarizing the essence of the International Diabetes Federation meeting, and communicating it in the community to improve the quality of diabetes care, to finally, on a global scale, walk away from diabetes. Thank you very much. Shukran for your activities.
Thank you, Peter. It was wonderful, and it was always very enlightening to listen to you. And we really very, very thankful that you could spare your very valuable time. And these 2 days program, which we have designed in such a way that some of the important topics which we can learn from this International Diabetic Federation, and particularly for those doctors who could not join. Just to say to all the board members and to everyone, we have almost 1,800 doctors who were registered for this meeting. And probably today we will have 1,300 doctors. Already more than 800 doctors already logged in, and I'm sure maybe 1,200, 1,300 will be there. But we have more than 1,800 doctors registered. Once all the speakers, once they will be talking, their digital recordings will be there, and which we are going to put on our website. A link will be sharing the link also to the doctors in different WhatsApp group. And I'm sure many hundreds and many thousands of the doctors who will not able to join today, they will able to listen it later on also. With these words, now I again request Dr. Basis Saab and to Dr. Vishwajit, who is our secretary, to introduce our first speaker, and then we can take the scientific. Thank you once again, Peter, for very, very valuable time with us. Dr. Nadima and Dr. Meshwa is there. Nadima told that she will be joining a little late, but now I can request Dr. Meshwa, he is already there, who is a senior consultant endocrinologist and internal medicine from Egypt. He is also the past president of our DASG, and he is very active member of DSG. Currently, he is chair-elect of IDF MENA region. Now over to Dr. Meshwa for introducing our speakers. Dr. Meshwa.
Okay. Hello, everybody. Hello, Banshi. Hello, all the faculty and my co-chair, Nadima. First of all, I want to congratulate all the friends in our DASG for this perfect organization. I am sorry to join somewhat late because I am in Beijing now, and some disturbance on the connection happened. But it is my pleasure to introduce our first speaker, Dr. Nihal Thomas. Dr. Nihal Thomas is one of the senior professors in endocrinology and from India, and the vice principal research and associate director, deputy medical superintendent and endocrinology also. He has more than 330 indexed publications, and also if I repeat what is in his biography, it will be very very long, but he has very important participation in all the research and the papers, and recognized by the British Medical Journal for the pathology team as the year 2015, and the Royal Colleague of Physicians Award for Excellence in Teaching and Training. Dr. Nahal Thomas will starting now his presentation, and I think that all of us in desk and outside desk will be impressed by his one, as he is one of the most talented peoples and the most respected researchers. Please, Dr. Nahal.
Thank you. So, Dr. Meshwa, thank you first of all. And just to introduce Dr. Nihal Thomas, is we already introduced, but just to tell that this time a type 5 diabetes, which we discussed during International Diabetic Federation, IDF support, it was his initiative. He started, and he will be talking in next 15 minutes about some very important topic, which we had discussed, and it had become, talk for each and every diabetologist across the world, that what type 5 diabetes. So he'll be talking, Dr. Nihal Thomas, who is a senior professor of endocrinology from very prestigious institute, what they say, Christian Medical College, CMC Vellore. So now, without wasting much time, I will request Dr. Nihal to start his slides, and immediately after talk, with each talk, we will have one or two questions, and at the end also we can have more. Once again, I request the AV team to record it dedicatedly, so later on after his talk, we can put this presentation also on our DSG website. Now over to Dr. Nihal Thomas. Thank you.
Thank you, members of the Diabetes Asia Study Group, Dr. Misbah Kamel, Dr. Banshi Sabu, Dr. Abdul Bashid, and everyone else. Such a pleasure to be with you over here. And I'm going to be talking to you very briefly about type 5 diabetes. What exactly is the disorder? So I just cover my talk under these subheadings. And so, as mentioned, during the IDF, this announcement was made by our very dynamic president, Dr. Peter Schwartz, when he made this announcement of type 5 diabetes coming as a major entity which should be given due recognition. The story actually started about a few months before, when a group of us, about 40 experts from across the world, who looked at nutrition, undernutrition, and diabetes over many years, decided to actually come to a consensus. And this is in Vellore in India. Now, let me actually come to the point as what I mean by lean, because it's a most maligned and misused word. But if you go by this Lancet definition, we say that someone is lean depending on which population you're talking about. So, in the South Asian population, that is precisely less than 19.2 kg per meter squared. Depending on other populations, obviously, like particularly in this group, if you're talking about the MENA, the Arab populations, about 22.1 kg per meter squared. And of course, WHO has a categorization of malnutrition or undernutrition as less than 18.5 kg per meter squared. Now, let's first look at what we think about when we see people with low BMI diabetes in a country like India and perhaps in much else of the other world. You should think of type 1 diabetes or its formifraste, that is the slowly evolving immune-mediated diabetes for anyone less than 30 years of age as the most important cause. And then there are other causes as well. I would like to highlight particularly the ones in green as the ones which would be more common. And then I come to the point, once you rule out other conditions, you think of a possibility of type 5 diabetes. So to rule in, you need to rule out the other conditions. So this condition was described way back in the 1950s in Jamaica. And these criteria were laid down by Tripathi and Samal way back in the 1990s, talked about a fairly severe form of diabetes, what they called high glucose levels, lean phenotype, poor socioeconomic background, ketosis resistant as a major categorization, and requiring more than 2 units per kilogram of insulin per day. They mandated insulin. Rule out all other common causes for lean diabetes. And at that time, fibrocalculus pancreatic diabetes was rampant in tropical areas. However, after the initial recognition by the WHO, it was erased off the classification based on the fact that there was no physiological evidence for the disease. People thought it was just poorly controlled type 2 diabetes, which had lost a lot of weight, or just under-recognized or unrecognized type 1 diabetes. More recently, it has been recognized in many other countries over the last decade and a half. And this prompted us to think about this condition further, followed by a physiological study which was performed as a collaborative venture between New York and Vellore in India and published in the year 2022. So these are the studies which actually prompted thinking about it again. Several publications, particularly from Africa, and other parts of the world like Jamaica, as well as some parts of Asia, made us think that this condition certainly did exist and was a unique entity. So why does it happen? Let's look at the pathogenesis. If you look at type 2 diabetes, and there's a reference for every one of these 21 points, the risk factors for type 2 diabetes. But I'll come to one point, and that is low birth weight and their historical determinants, which could be a common overlap between type 2 diabetes and the entity which I'm going to be talking about. So let's focus back on the Barker hypothesis. If you're born low birth weight, according to David Barker in the Hertfordshire cohort, you're more likely to get diabetes, hypertension, and obesity as you grow older. That is known. And it's no longer a hypothesis, it is a well-known fact that thrifty phenotype does exist. And many other cohorts during wars in Europe, as in the Dutch hunger famine, and many others have shown the same. Inequity is an important issue across the world. It's something which we wouldn't pride ourselves to talk about. But just to notify ourselves that low birth weight is common. And in a country like India and in South Asia, we have some of the lowest birth weights in the world. May not necessarily be always undernutrition, it could be a transgenerational impact. There is also an aspect of stunting and undernutrition, which once again, if you look at the patches of yellow, orange, and maroon, are the commoner areas where stunting and undernutrition might actually occur. So this is a study which was done back in Velo about 15 years ago, looking at people who are born low birth weight after the age of 18 or 19, using hyperinsulinic euglycemic clamps, NMR spectroscopy, and measuring fat in the liver and the muscle. Now, if you're born low birth weight, and at the age of 19, you have a BMI of, say, around 19.5, which you are relatively lean, but not having a good diet, relatively speaking, reduced muscle mass, increased body fat, and a tendency towards a low protein diet with a diastolic blood pressure being slightly higher than normal was seen in the low birth weight. But there were no features of insulin resistance despite the increase in fat at this particular point of time because there was no overnutrition in this group. Let me focus on malnutrition per se. And if you look at it over here, we talk about malnutrition in two categories, marasmus and kwashiorkor. And these are things which I would have seen about 40 years ago. But the marasmic group live longer and they are afflicted by nutritional issues which may lead to a problem with beta cell deficiency. You don't need to have gross marasmus, but undernutrition per se can affect the whole thing. And here are renditions and studies which have shown that undernutrition can lead to beta cell dysfunction if it's chronic. Undernutrition can also lead to a problem with GLP-1 secretion defects. The other factors, these two factors could therefore lead to problems with glucose intolerance. Pancreatic studies in malnourished rats have shown this phenomenon of microislets, beta cells which are much smaller when compared to well-nourished or normally nourished rats. Coming back to the Barker hypothesis, we talked about low birth weight and we talked about overnutrition, and that's in the postnatal phase. As you get have overnutrition, you have a tendency to develop type 2 diabetes. If you have undernutrition, on the other hand, you tend to develop what we call type 5 diabetes. So it's a double hit, a double whammy, undernutrition in utero, subsequently leading to undernutrition postnatally, and therefore type 5 diabetes. So this is the basic framework of what you have in terms of the pathogenesis. Physiological studies were lacking, as I mentioned. And back in 2022, we came up with this publication, a collaborative venture between the United States and India, utilizing the same tests which I mentioned, very intense studies, the hyperinsulinic euglycemic clamps, the NMR spectroscopy, indirect calorimetry, and genetic testing in all our patients. We compared type 1s, type 2s, the lean diabetes, which I'm talking about, lean normals, and obese normals. And we did all these tests. It took almost 7 years to get this done. Now, what it shows, and also which can be alluded to in a recent publication by us in the journal Physiology, this disease does not have a standard autoimmune or genetic etiology. It's ruled out. The BMI is very low. They have poor insulin secretion, but not as low as type 1 diabetes. There is no insulin resistance. They have hepatic glucose output, which is there, but not as high as type 2 diabetes and not as low as type 1 diabetes. The percentage body fat is low, generally less than 20% of the total body, which is actually very low for any kind of diabetes. And they generally have a tendency, even if they are well off, to consume much less protein, fiber, and micronutrients. So this is a physiologically different entity. The interesting thing is that 50% of them, despite being insulin deficient, do respond to oral anti-diabetic agents. And this is not in the presence of any genetic MODY or monogenic disorder. So from a clinical perspective, as physicians, like most of you are online today, we need to rule out the conditions which I said, particularly the ones in green, before you think about this particular condition. And this is the algorithm which we follow: a good history, a good pedigree chart, physical examination, C-peptide levels, at least a random C-peptide level, if not a fasting and a postprandial. The GAD antibodies, if possible, to rule out slowly evolving immune-mediated diabetes or type 1 diabetes, and an imaging of the abdomen to rule out pancreatic disease. The other tests may not be mandated and may be difficult to do in a resource poor area. So here is fibrocalcic pancreatic disease. It is still very much around in the tropical areas. It is still a problem in India as well. Not as common as what it used to be, but it's still there. 70% male, non-alcoholic, low C-peptides with fat malabsorption. And of course, an increased propensity for malignancy if they live long enough with good treatment with insulin and enzymes. They do not have a glucosamine deficiency in the initial phase. In fact, paradoxically high, and the energy expenditure is high. Now, why am I saying this is an important differential? Because there's an overlap in the areas where protein deficient diabetes, or the type 5, which we call it today, and fibrocalcic pancreatic diabetes, there tends to be an overlap in the countries where it occurs. So please do an imaging of the abdomen. A CT is optimum. An ultrasound may miss about 40% of cases. Monogenic beta cell dysfunction, MODY, and beyond that, there are 62 genes which can actually cause beta cell dysfunction as an autosomal dominant or occasionally an autosomal recessive condition. Rule this out. This is a good pedigree chart which has been drawn looking at the paternal side, autosomal dominant, and it's a MODY1, a HNF4 alpha mutation, one of the many monogenic causes. Now, there are some which are lean, particularly the monogenic MODY5, not type 5 diabetes, but MODY5, which is an inherited condition where they can be extremely lean and can be insulinopenic. That condition can be mixed up with our type 5 diabetes. So I talked about the three conditions, and let me come to a prototype case before I end. 17-year-old individual came at the age of 17 with diabetes, osmotic symptoms, weakness, lot of weight loss, but there was diarrhea, but we ruled out other conditions. He had a history of a low birth weight, which was obtained in this history. He was otherwise normal, but belonged to a low middle class family. And this was his examination finding: low BMI, suboptimally controlled glucose levels, and his other tests were negative. He did not have fat malabsorption, nor did he have any features of type 1 diabetes. The C-peptides were low, but showed some sort of a response in the postprandial phase. And this is typical of this particular condition. The ultrasound did not show pancreatic disease, and there was no fatty liver. The percentage body fat was very low, 17.4. And this is not due to high osmotic loss of glucose or that kind of secondary malnutrition, because it is very low. And even after controlling the sugars in this patient, it stayed in the range of around 19, 20. It did not rise significantly. We did a genetic panel. You don't need to do this routinely, but from a research perspective, we ruled out monogenic disease. So here, this patient has a lean, young onset, non-autoimmune diabetes with insulinopenia, normal pancreatic structure. This patient has type 5 diabetes. And subsequently, he was well controlled with oral antidiabetic agents, glimepiride and sitagliptin in addition. Now, we don't have an algorithm for treating these patients with which oral antidiabetic agents. There's a lot more work which needs to be done to understand the therapeutic regimens. Here's another patient, 32-year-old male, BMI of 17.4, birth weight 2.3 kilograms, initially on oral antidiabetic agents, no ketoacidosis. Glycemic control was poor, antibodies were negative, insulin levels, C-peptide was borderline, and stimulated C-peptide 2.35. Percentage body fat, a little higher over here, truncal fat 21%. Now, this indicates very good insulin sensitivity, extremely good insulin sensitivity, but the patient eventually required low doses of insulin for control. So this is a variant of this particular condition. So let's try and get some criteria, and we are in the process of deciphering and involving criteria. Generally less than 30 years of age, poor socioeconomic status, lean phenotype, absence of ketoacidosis, low C-peptides fasting with GAD antibody negativity, low birth weight, if you can get a birth weight history, absence of insulin resistance, rule out other pancreatic disorders, and if you can do a body composition, even without a DEXA, a bioimpedance, you will see low percentage body fat. Treatment, insulin response in 50%, and the remaining 50% who are lucky, you can manage with oral anti-diabetic agents. So thank you very much for your patient listening, and I'd be very happy to answer any questions. Many funding agencies and many colleagues who I've worked with over the years, many photographs which I cannot show, but thank you once again, team, for enabling us to do this work. Thank you.
Thank you,
Oh, thank you very much, Professor Nahal, for this elegant presentation. And I think this is a very hot topic nowadays because of our region. We are involved in it, because of the peculiar diagnostic criteria. I think in the future there will be more and more markers that can delineate the differentiation of this important type, and regarding the therapeutic challenge, that more than 50% of it with the oral can be treated with oral sulfonylurea and the DB4 inhibitors, and so there will be no burden on the resources, but the burden will be on diagnosis and for looking for this possibility. Thank you very much, and I think I have one question leading this opportunity. Is this any biomarkers more than this criteria of the low body weight and the non-ketotic state and the non-insulin resistant? Is there any biomarkers else regarding the fat, regarding the...
So there has not been any other biomarkers which have been identified, other than the fact that you have an insulin deficiency with a ketosis resistant state and no evidence of peripheral resistance. So just putting the constellation together in this scenario by ruling out other conditions, you make the diagnosis. So there is no specific biomarker per se, but I think it's the history and the other biochemical tests that we need to do. But of course, a lot more work needs to be done to try and...
diagnosis, yes.
Beg your pardon, sir?
We need to rule out the other diagnosis. You put
Absolutely.
it in green. This is very important because sometimes there are mixing of the clinical states that you must differentiate. So it is up till now, it is a matter of high clinical suspicion and the differential diagnosis.
Very. So Nihal, wonderful presentation. There were many questions, but one very important, then how will you differentiate between severely insulin deficient diabetes? Because one of the cluster of type 2 diabetes, which was SID, and they were autoimmune negative, and they were also with the low BMI, and they were also having the C peptide was less with these people, and they also respond to either to sulfonylurea or insulin. The only thing which I could say here that you had shown very clearly that with DEXA or with BCA, there was a low fat percentage. I mean, the fat percentage was also low in compared to a typical lean type 2 diabetes where insulin resistance is still very high. So that was one thing. So how will you differentiate? And what's the difference between SID and the people who are with type 5 diabetes? Or are we saying that those patients who are SID, probably one variety of SID patients are pancreatic, or I mean, they are type 5 diabetes only? I mean,
so this is an excellent question. And so the point here is, if you look at most of the studies on SID, number one, they have a wide spread in large epidemiological studies, and the BMI can vary even in the Indian cohorts from as high as 23.5 kilogram per meter squared. Secondly, SID does have lower C peptides, but they generally don't drop to very low levels. Thirdly, as you mentioned, the percentage body fat is not as low as what you see in this condition. Having said that, when you do large epidemiological studies, there could be a mixture of type 5 patients in the SID group and vice versa. You could have SID patients in the type 5 group when you do large epidemiological studies. So the other thing is, in most of these epidemiological studies which have looked at SID, we don't have birth weight records, etc., which have been matched. accordingly to the situation. But yes, the overlap between these two conditions is something which is of great interest and is a fascinating area which we should be doing a lot of research. Thank you for that question.
So, I mean, each and every patient, two important thing is low birth weight. Continuously, they are having low BMI. And the third is their fat percentage is also low comparative with that. And with low C-peptide level, with autoimmunity negative. So do you think that each and every patient should go with the BCA if you find someone with a negative autoantibody for type 1 diabetes, and if you are not suspecting monogenic diabetes, we should subject them to either DEXA or BCA? I mean, that's what the primary care clinician should
So,
do for their patients.
yes. So if there is no strong family history, your C-peptides are low, your autoantibodies are negative, and your imaging of your pancreas is normal, this should be considered as a potential important cause.
So we can
Yes,
think of in near future a sort of a registry for these type of patients, maybe to get more data from around the world and from which part of the
Certainly.
world we
Certainly.
have
I
more.
think that's an important mandate that people who have three areas, registry is one, clinical registries. Second is large prospective cohorts, which are already there, and also taking into account previous retrospective databases where we can data mine the bottom centile, the low BMIs, and try and understand whether we see more of these patients in that particular category.
So long-term study will give us a lot of answers for these things. And I'm thinking that DSG, Diabetes Asia, where a lot of people from this type of people will be in Asia or in Africa. So maybe DSG will be very happy to, get this type of cohort or registry from Diabetes Asia also. Thank you, Niyal. Wonderful presentation. Now I request Dr.
Pleasure. Thank you
Meshwa
so much.
for, yes, thank you. I request now Dr. Meshwa to introduce our next very eminent speaker, Dr. Riaz Malik. So, Dr. Meshwa, once again, you, if Nadima had not joined. Over to
yes.
Dr.
Uh, okay, thank you, Banshi. Thank you, Dr. Nahal. And now we will have an appointment with uh, one of the most important figures in diabetology and especially caring for diabetic complications, microvascular diabetic complications. Professor Riyad Malik. Riyad is our dear friend. He's a professor of medicine and coronary medicine in Qatar, and remains one of the figures in our region. He was one of the eminent researchers and contributors to the field of diabetic neuropathy, and he was the president of NeuroDiab, the diabetic neuropathy study group of the ECD from 2009 to 2012, and he is recipient of the prestigious 2019 Golgi Prize from the European Association for the Study of Diabetes, and the Gulf Association for Endocrinology and Diabetes, and gold medal. And he go in depth for the research in neuropathy as one of the challenging complications of diabetes. And I think Riaz will give us very good insight in the next minutes for dealing with the problems that facing every physician
Thank you, Ms. Bash.
treating the diabetic patient. Please, presentation.
Let me get my presentation up. Oh, hang on. Here we go. Okay, so I hope you can see my screen. Thank you, Ms. Bash.
Yes. Yes.
So I'm going to now give you a brief update on the diagnosis and management of painful diabetic neuropathy. These are my disclosures. So painful diabetic neuropathy, we're all aware, is this condition which previous studies have actually shown, which have been from Europe and the US, have shown that 1 in 5 individuals with diabetes will get this condition, which is pain in the extremities, worse at night, characterized by pins and needles sensations, electric shock-like sensations, shooting, burning sensation, but also some numbness. So that was really studies from the Europe and US. Now, what are the studies like in this part of the world? Well, we actually did a study from Qatar where we looked at over 1,000 individuals with diabetes, and we actually showed that the prevalence of painful diabetic neuropathy, as assessed by the gold standard tools that I'd been previously using in Manchester, was actually 34%, higher than we'd found previously in Manchester. So why was that? Well, one of the main reasons was actually that a major risk factor for painful diabetic neuropathy is obesity. And that is highly prevalent in Qatar and in the Middle East. So that is a major risk factor, and smoking as well. So those are major risk factors for painful diabetic neuropathy, increasing the prevalence. But the most important finding is this, that actually 80% of these patients that we had now diagnosed from primary and secondary care had not previously been diagnosed. And that to me was shocking, because I thought, this is terrible. Maybe in this part of the world, we just don't have the time, or we don't ask the questions. But actually, if you look at the literature, it's across the world. Diabetic neuropathy is just not diagnosed. So undiagnosed diabetic neuropathy, you can see whether you look in Qatar, which is 80%, even the USA, 79%, Thailand, 65%, and other places like Germany, 91%, Saudi Arabia, 98%, are just not being diagnosed. So are they not being diagnosed with the painful diabetic neuropathy or diabetic neuropathy because, well, we're too busy, or maybe we haven't got the tools to help us to assess this quickly and efficiently? And that's where really we've now started to look at maybe trying to make a change. And what we're suggesting is a newer, simpler screening tool for painful diabetic neuropathy particularly. And this has been put together through an expert panel from over 18 countries. And what we essentially did is we looked at all the questionnaires that were currently available, including LANS, DM4, MPQ, Pain Detect, ID Pain, and clearly they all perform very well in clinical research studies. So they all have sensitivities and specificities which are above 70%. But the reality is that in the clinic, we just don't have time to apply any of these tools. And so we thought, well, what are the key features and how quickly can we maybe assess patients? And so we thought, okay, first of all, you need to have some way of capturing the main symptoms. Then you need to know something about the severity, whether or not it is worse at night, and whether or not it's symmetrical. And so if you apply that together with very quick sensory testing, right, which is assessment of pinprick and cotton wool, then actually the ACT tool, that as we call it, you can do in 2 minutes, 20 seconds, versus what everybody wants to use or maybe is endorsed, which is the MNSI, which actually, if you do it in clinic, takes over 14 minutes. So far, we've actually now got actually close to about 500-600 patients, but this is a study, just shows you how a quick tool could be efficient. So this is 19 patients in my clinic where we've used the ACT tool and compared it to MNSI. We actually showed that when we do this, we get very good or reasonable Cronbach's alpha, which is the reliability of the tool, but we get a sensitivity of 82% and a specificity of 78% for identifying painful diabetic neuropathy with this tool compared to the gold standard tools like the MNSI. So based on that now, actually, with the International Diabetes Federation, through funding from Procter & Gamble, we are now validating this tool in probably actually is going to end up about 3,000 patients, but in Qatar, Thailand, India, Brazil, Ecuador, and I've already been asked whether or not we can do it in Pakistan, and in the Philippines. So hopefully, inshallah, we'll get this validated and to be used in the clinic. So beyond that, of course, I have to talk about, what is the underlying pathophysiology of this condition? Well, we know that the underlying pathophysiology is damage to the small fibers. And these are the small intraepidermal nerve fibers which get damaged, and both damage and repair actually is what signals the pain. So why are we not diagnosing this condition? Well, the simple answer to that is that the tests that we're doing in our clinics are the wrong tests. We have small fibers that are damaged, and yet all the clinical neurological tests that we do, whether it's neurological examination, monofilament, vibration perception, nerve conduction, what do they measure? Large fibers, which is not the small fibers which we should be measuring if we're going to get any handle of what's happening in terms of pain. Now, there are, of course, quantitative sensory tests, small fiber testing, but I want to just quickly share with you a tool that is maybe some people say is not widely available, but I can tell you there are 2 centers in India that have got it. There's a center in Pakistan. In Qatar, unfortunately, we have actually got 5 of these microscopes, but it does assess small fibers very quickly. And in fact, what you can do is literally look into the eye and measure nerve fibers. And when we do that, what we have are data, compelling data to show that if you do take people with painful diabetic neuropathy compared to painless diabetic neuropathy, compared to healthy controls, there is a consistent loss of nerve fibers, small nerve fibers in the cornea in like 4 different parameters. And furthermore, there is actually a relationship between severity of pain and the extent of loss of nerve fibers. So the more severe the pain, the greater the loss of corneal small nerve fibers. But is there anything we can do for diabetic neuropathy or painful diabetic neuropathy, or do we just diagnose it and then say, well, I'm sorry, but you've got this problem, but not much we can do for it? Well, if we look at the targets for painful diabetic neuropathy, there are 3 main targets. One is the periphery, which is where I believe the problem starts. Unfortunately, most of the medications that we use aren't really approved by the FDA for use in the periphery. So capsaicin works. Recently got an approval actually from the FDA. Local anesthetics, don't really use them either. NSAIDs and COX-2 inhibitors might work, but not really very effectively. But then we have the spinal cord. And the spinal cord, of course, we have 2 major pathways, which is the ascending pathways, which are going up to the brain. And here we have really the alpha-2 delta ligands like pregabalin, gabapentin, tricyclic antidepressants, tramadol, and opioids, which all work on this ascending pathway, blocking the passage of these pain signals up to the brain. And then we have descending modulation, which is actually putting a brake on these signals coming up the spinal cord. And this is, of course, through the SNRIs like duloxetine, tricyclics, tramadol, and opioids. But as you can see, the FDA-approved drugs really are working in the center as opposed to the periphery. And the latest trial data from the Option DM study actually shows us that all of these drugs seem to work, but not really that effectively. So amitriptyline is comparable to duloxetine, is comparable to pregabalin for the reduction of pain, but you only get 50% pain relief in about 50% of patients. And even when you combine the drugs, you only get another 5% benefit. So the question is 50% pain relief in 50% of patients enough? Can we do better? I believe there are better drugs actually, which we need to start to kind of understand their use and get them approved actually. So one such drug is crazogabalin, which is now approved in China, but not yet approved by the FDA in the USA. Why? Because the Chinese developed it. So what is it? Well, actually, this is an alpha-2 delta ligand modulator, but it has a binding affinity which is 23 times more powerful than pregabalin. So what does this mean? Well, if you take in a study when you compared it to pregabalin, what you find is that overall pain relief, average daily pain score is as good as pregabalin. But the effect that you get is much quicker with crazogabalin because of this binding affinity. So within days, day 2, day 3, you already get a separation with crazogabalin compared to pregabalin, compared to placebo. You can see pregabalin is taking about maybe a week for it to start to work, whereas crazogabalin works much more quickly. Then we have the new world of actually, well, it's an old world, but it's a new look at sodium channel blockers. Now, what are sodium channel blockers? Well, they're actually drugs that work on the periphery. So these are voltage-gated sodium channels, which is where the pain starts. And we've actually done studies now, genetic studies from the ProPain study, which shows that these are no longer the, 2% of the population might have this problem, but actually 21%, 1 in 5 individuals have variants, which are abnormalities in the genes that code for voltage-gated sodium channels 1.7, 1.9. And there are also smaller numbers, but nevertheless, there are patients with variants in genes that would modulate potassium channels and TRP channels. So ion channel modulation, I think, is going to be the new future, where I believe that when we modulate these peripheral channels, we will then be able to use higher drug doses without the side effects, the central side effects. And so we have now got suzetrigine, which has been approved for acute pain by the FDA just about 2 months ago, but we have also got ongoing trials in painful diabetic neuropathy. So this is actually gone head-to-head with pregabalin. And what you see here is that overall the pain relief actually is pretty comparable with pregabalin, okay, at that dose. However, what the big difference is that in the pregabalin group, you get the side effects. So you have weight increase, headache, dizziness, somnolence. But in the suzetrigine group, which is working at the periphery, actually very little side effects. And we also have now another class of drugs, which is the first of which is pilavapadin, which was approved, not approved, top-line data released in March the 5th, 2025. What are these group of drugs? Well, they're the adaptor-associated kinase AAK1 inhibitors. These block endocytosis and actually work on alpha-2 adrenergic signaling, which is a major modulator of pain. There is a study of about 500 patients, the PROGRESS study, which allowed the use of pregabalin, gabapentin, and duloxetine, and this was an add-on. And this has just been published in Diabetes Care and basically shows that if you add this drug to people who are already on pregabalin, gabapentin, you get a further reduction in pain. But sometimes obvious conditions and treatments are the most difficult to grasp, and one of those is vitamin D. So vitamin D, we and others have shown, is lower in people with painful diabetic neuropathy compared to painless diabetic neuropathy, particularly if you have a level less than 20 nanograms per mil. You have a 9.8-fold increased risk of painful diabetic neuropathy. And to the rescue, we were talking about this, we should be doing studies in this region. And actually, with Abdul Basit, we did this study in Pakistan because I couldn't get funding for this to do this study in England. And what we did is we did a study with vitamin D3, 600,000 international units intramuscularly, followed up for 20 weeks. They had remarkably good vitamin D levels, 31 nanograms, which most people wouldn't treat. But when we treated it, it went up to 46 nanograms, but look at the pain. Total McGill pain score came down significantly. It's as good as pregabalin, as gabapentin, as capsaicin. And that we improved the quality of life. So, and lastly, B12, which actually, when I came to this part of the world, everybody's on B12. And I wondered, why are they on B12 if really the evidence at that time was pretty, I would say, tenuous. But this is a study from Greece that has looked at oral B12 supplementation, 1,000 micrograms against placebo over 12 months. Important to note that the B12 level was 232 to start with, and it went up to 776. You can see in the placebo group didn't really change. But then you get an effect in terms of quality of life improves, pain score goes down, even nerve conduction improves, and that didn't happen in the placebo group. So I'd like to stop there And thank you. Misbah, over to you.
Yes, thank you very much, Riyad. As usual, this is an elegant presentation. What came to our mind now that the first issue you concentrate that early diagnosis must be the rule, and the using of the classic teaching tests for neuropathy now are not validated because this is the large fibers, and now small fibers must be assessed first. This one thing. The other thing that also the wide range of the therapeutic modalities tried. This gives the idea that peripheral neuropathy is not a peripheral, but it's a central issue in the pathogenesis.
No, it starts in the periphery, but there is modulation in the center through the spinal cord and through the brain. And we know pain is modulated. And actually, maybe by default, we've not had any good drugs that have worked on the periphery, although carbamazepine is a good sodium channel blocker. And for the older individuals here, you'll know that carbamazepine sometimes works very well for particularly, lancinating type of pain. So by default, we've actually just, we've gone for the centrally acting drugs. But the problem with there is the side effects. And we know that we can't push up the dose. So
yes.
I hope
what about
Well,
yes?
Riyad, sometimes
Yes. What about
even
the
with
modality? What about
sorry?
the modality of the electric therapy for the spinal cord and the tract pathways, the electric stimulation?
Yeah, spinal cord stimulation is there, and there is evidence, actually recent evidence, that shows that it is effective. It's very effective. However, that is an invasive procedure which we don't really have access to. Even in place like Qatar, I have difficulty. I can't get it done actually because it requires you to implant the spinal cord stimulator. There are of course FREMs and TEMs that people use, but their efficacy isn't that well proven.
Yeah. So you recommend to regarding vitamin D to go with vitamin D supplementation and no need for assessment of vitamin D deficiency or no in the lab?
Honestly, no. I mean, I can say that, all my patients, whenever I've checked them, they're all deficient, right? I mean, there are very few people I come across, honestly, that have a normal level. And you can see from that study that I did with Abdul Basit, the average level was already 29. And that's not because they were not deficient, but they were already being treated by probably their physicians. But even then, when we gave them that 600,000 units and it went up to 47, the pain came down. So, and I know there's an issue, there's a cost. We don't all have access to laboratories, and there's a cost of checking for vitamin D. And I don't believe that's needed in a pragmatic sense. In an ideal sense, of course, I would love to do it.
Nihal has got his hand raised.
We have a
can I
question
just request
on
Nihal?
the chat that
Nihal wants to ask.
what are the sodium channel blockers available?
Well, carbamazepine is already available to you, and the new one, suzetrigine, and there's another 3-4 major ones coming through from different pharma companies.
Riyad, last question regarding tricyclic antidepressants. Where you would put, I mean, after using all the routine medication like duloxetine and carbamazepine, and then you would like to put them on, if someone pain is still very, very high, would you like to put them on amitriptyline, nortriptyline, gabapentin? What's the situation? What do you do in your clinical practice?
In my clinical practice, honestly, a long, long time ago, I used to be, my tricyclics were my go-to drug, amitriptyline or imipramine. And then we kind of, obviously 20 years ago, pregabalin, gabapentin came along. We said, okay, maybe these are better drugs because they don't have as much side effects. But I still use in some patients, and it works very effectively, 10 milligrams of amitriptyline. It's not the highest dose, but it works. So, it's cheap, it's effective, but the elderly, I tend not to use it.
Right, very true. Thank you once again, Riaz, for a wonderful presentation. Thank you very much for joining. Once again, thank you, Very, very wonderful. Yes, Dr. Vishwajit, you want to have some questions?
Nikhil has some questions.
Please.
Nikhil. Nihal.
Nihal wants to have?
Yeah,
Nihal,
yeah.
you want to
Sorry.
make some
Okay,
comment or
if
question?
there
Yes,
is
Nihal, please.
time, the vitamin B12 levels that you've shown, which in terms of correction is pretty much endemic in vegetarian populations in India. The question is, has the set point changed over the years? Why is it that I don't believe that B12 levels have always been as low as what they are in our populations, in vegetarian populations? What is the relevance in terms of the set point? Has it shifted due to some reasons to have actually induced symptoms of pain at a relatively normal level? Point to ponder, maybe may not be able to give the answer right away.
We need to think about that, but I don't know. I honestly don't know. I mean, I even sometimes kind of should we say not easily understand the direct connection between B12 levels and the generation of pain. You know, I mean, there are some animal studies that show that they modulate even sodium channels. Actually, B12 somehow does this, and there's you know, changes in terms of Schwann cells, but I'm not sure how easily translatable it is. But yeah, I don't know.
Thank you. Thank you.
Okay, thank you, Riaz. Now I request Dr. Alice.
Yes.
Alice, will you?
I think now.
So, Professor Meshba, please introduce Dr. Alice. She is from Hong Kong, and you can understand the time difference. And we are really thankful to her that she joined live because almost 6 hours. She is already middle of the night, maybe around 11:30. What's time just now, Alice? Please start.
Yes,
And Meshba, you can introduce
it's my
her.
pleasure. My pleasure, Banshi, to introduce Professor Alice Kong, professor in the Department of Medicine and Therapeutics at the Chinese University of Hong Kong, consultant at the Prince of Wales Hospital, Hong Kong. She is had her overseas training as postdoctoral fellow under the mentorship of Dr. Robert Henry at the Division of Endocrinology Department in California, and also her research into diabetes with particular focus on lifestyle factors, including sleep and diet in adults and adolescents. She is also a reviewer of many local and international journals, including Annals of Internal Medicine, Diabetes Care, Clinical Endocrinology, and associate editor of the Primary Care Diabetes and an editorial board member of Current Diabetes Board. Presenting numerous local, regional, and international meetings, presentations, and published more than 200 articles in peer-reviewed journals. Dr. Alice will speak about sleep and diabetes, and this is a very important issue nowadays. Please, the floor is yours, Dr. Alice.
Thank you. So can you hear me?
Yes.
Hello.
Yes.
I'm not sure you can hear me well.
Yes, we can hear you well.
Please share the presentation.
Well, I think I sent a report. Yeah, I'm not sure how I can share my screen. Let me see how I can. Yeah, can you see my screen?
Yes, now
can see you.
Great. Okay, so thank you very much for this opportunity to speak, and thank you very much for the kind introduction. So my name is Alice Kong. I'm a clinical endocrinologist, and I'm very happy to this opportunity to share with you what I have spoken during IDF Bangkok last month, and the title of my talk in diabetes. So I would like to have a minor change of the topic to interconnection between sleep, depression, and diabetes. This is my disclosure. I didn't cut any of my slides, although I know I have less time allocated compared to my talk when I delivered the lecture in IDF. And so I will be a bit concise for each slide. I would like to highlight that the reason why I want to have a minor change of the topic, because these three conditions, sleep problems, diabetes, and depression, are really important and prevalent conditions, and these conditions are interconnected. Well, last month in IDF at the Bangkok, as one of the delegates, and many of us are very eager to know about the latest epidemiological data about diabetes prevalence, and happy to share with you the latest IDF Diabetes Atlas, the 11th edition, and not surprising to know the number of people with diabetes are increasing, and we have 589 million people are living with diabetes across the globe, and the number, expected to increase further by 2050 to 853 million. Many parts of the world, we have increasing number of people with diabetes, and in Asia, where we are staying, have a very, important increase, just second to Africa. And this I want to, highlight that diabetes is one of the four main groups of NCDs, non-communicable diseases, which killed 3/4 of people across the globe. And in parallel with this rising global prevalence of diabetes, there's also increasing number of people with sleep deprivation. No matter young people or, older adults, they increasing demand due to work or various commitment. We cut the number of hours per night to sleep. And from compared to 1 century ago, that the average hour of sleep per night is about 9 hours. Now that many of us sleep less than 7 hours per night. And also with modernization, we're actually facing a lot of energy-dense food, and also sedentary lifestyle, decreased physical activity. Also, we are having increasing stress, chronic stress. And in this sleep deprivation is in a kind of chronic stress. And I wrote this review article with my postgraduate students summarizing the evidence regarding mechanistic link why sleep deprivation can increase the chance of obesity, because when somebody got chronic sleep deprivation, that will activate our neurohormonal system, increase our cortisol, increase our sympathetic drive, increase the bad hormone, the ghrelin, that stimulate our appetite to eat, and decrease the good appetite regulating hormone leptin. And these work together to increase the chance to be obese. And once obesity sets in, there will be comorbidity like sleep apnea, and that grew as vicious cycle, further compromise the sleep quantity and quality. And my group and other researchers across the globe also demonstrate that sleep-deprived individuals increase chance to have dyslipidemia, and all these increase the chance of cardiovascular diseases. So I have to declare I'm a strong supporter of lifestyle therapy for diabetes management. And apart from the tradition, good diet, regular exercise, 100 minutes per week exercise, behavioral, support with also smoking cessation. I'm so happy to, know that American Association of Clinical Endocrinologists since 2019 has included sleep as one of the components of lifestyle therapy. It was recommended to sleep about 7 hours per night with basic sleep hygiene, screens for sleep apnea. And 1 year later, actually, you are aware that it's more precise, a little bit change of the sleep duration to about 6 to 8 hours per night. I'll show you evidence why they have such an amendment. And indeed, for many, many years, we still not fully understand sleep. We all know that we need to sleep, but there's actually no consensus regarding the primary role of sleep. Sleep is proposed to play a role in learning, memory consolidation in our immune system, to fight the germs, toxin clearance, energy conservation, etc. As mentioned early on, why there's a kind of, change of this optimal sleep duration. I think one of the contributing evidence is from this Pew study, the prospective urban rural epidemiological study that include over 100,000 people across the globe in 21 countries, including Hong Kong, and with median follow-up about 7.8 years. And what they found, the optimal sleep duration is 6 to 7 hours per day, associated with lowest risk to have mortality and cardiovascular disease. And this U-shaped relationship, you can see that short sleepers associate with increased risk. I mentioned earlier on about the mechanism about neurohormonal dysregulation, why short sleepers have worse, outcome. Indeed, we are not sure why the long sleepers have worse outcome, and people postulate that extended sleep duration may be a marker of ill health. They might be undiagnosed cancers, undiagnosed depression. So we still not fully understand why long sleepers associate worse outcome. And I'm happy that I'm one of the researchers contribute to the body of knowledge regarding the association between sleep duration and also diabetes. And this is a study conducted in my team, including over 3,500 type 2 diabetes from the Hong Kong Diabetes Register, that we survey them and check the blood for glycemic factors, including A1C, fasting plasma glucose, and do questionnaire to survey their sleep habit. And what we found is a U-shaped relationship between sleep and glycemic control. And we can see that those short sleeper with short sleep duration during weekday, and also the long sleeper associated with high A1C. And also, the fasting plasma glucose also have a U-shaped relationship with the sleep duration between weekday and weekend. Well, this is the latest recommendation from American Diabetes Association, and then again you can see that sleep, highlight as an important, part of the diabetes management, and not only quantity is important, as you can see, optimal between 6 to 8 hours. The quality is also important, and insomnia is one of the sleep disorders that may affect sleep quantity and quality. And therefore, in my cohort, apart from studying the sleep duration, I also invited participants to fill in questionnaire, the Insomnia Severity Index, ISI, and use 14 as a cutoff to screen for those with insomnia. And what we found in our cohort with type 2 diabetes, with comorbid insomnia, they have worse glycemic control in terms of higher fasting plasma glucose, higher hemoglobin A1C compared to their counterparts without insomnia. So insomnia is one of the common sleep disorders. Also, we have sleep apnea and other sleep-wake disorders. I'm not so ambitious to talk all about them, and more focused in the subsequent of my talk about insomnia and diabetes. As mentioned earlier on, sleep, insomnia associated with worse glycemic control. Indeed, this is a very nice review article published in Diabetologia. Also highlight that insomnia in diabetic patients also have decreased quality of life, increased depression, and also increased retinopathy, although there's still a lot of unknown association, underexplored association between insomnia and other complications like nephropathy, neuropathy, and macrovascular complications. But what is insomnia? So insomnia is a prevalent condition. It is a dissatisfaction in the quality or quantity of sleep, with characteristics like problems in initiating sleep, in maintaining sleep, and frequent awakening and ability to return back to sleep. As mentioned, it's prevalent condition about 10 to 30% of the general population, and it's even higher in older adults. We do not understand the exact mechanism why there's insomnia, and it's believed to be a multifactorial disease. So why people progress from acute insomnia to chronic insomnia, and there's postulation about these 3P models, distinct factors, individuals with possibly with genetic predisposition, with some anxiety, personality, and also with some precipitating factors like life events, stressor, from stress from work, finance, or other situations, and perpetuating factors with maladaptive coping behavior. And just want to, with this slide, to highlight the similarity about the 3 Ps that for also for diabetes patient and insomnia. So also for the 3 Ps, kind of common in also the link between depression and diabetes. And indeed, there's a bidirectional association between depression and diabetes. And from data from meta-analysis and systemic review, people with depression had nearly 2-fold increased chance to have type 2 diabetes. And compared to people without diabetes, the rate of depression, no matter type 1 or type 2 diabetic patient, also increased. Okay, so why diabetes and depression are related? And there's postulation about possible mechanism, including in depressive state. There's increased insulin resistance, and also during depressive state, there's a kind of stress and then activated neurohormonal regulations. So you may all aware the 2C and 2G catecholamines, and also the growth hormone, etc. are the counteract the action of insulin. And also depression have a negative impact upon patient diabetes, causing worse glycemic control, increased diabetic complications, increased functional disability, and possibly with higher mortality. And this is a meta-analysis demonstrating that depression was significantly associated with a number of diabetes complications, including diabetic retinopathy, diabetic neuropathy, nephropathy, macrovascular complications, as well as sexual dysfunction. So now that we want to share with you a piece of data from my group that in Hong Kong, among nearly 600 Hong Kong Chinese with type 2 diabetes, we also studied whether they have depression using the questionnaire PHQ-9, and then we use a cut of 10, and then we found about nearly 9% of diabetic patients have depression. And those diabetic patients with comorbid depression, they have higher A1C, less likelihood to achieve A1C goal 7%, and also they are more likely to have self-reported hypoglycemia. And in our database, we also survey them with cardiovascular outcomes. So this is an analysis from my team that in 7,853 Hong Kong Chinese type 2 diabetic patients without cardiovascular disease at baseline. And we studied them between 1996 to 2008. And after median follow-up of 7.4 years, we found that 153 of them were diagnosed with major depression by the psychiatrist after review of the case notes and also the database. And over 800 died, and then 829 developed cardiovascular disease, mainly due to stroke. And what we found is that you can see the solid line are the diabetic patients with major depression, and compared to their counterpart without depression, they have higher incident cardiovascular disease. And kind of similarly, diabetes with comorbid major depression also have increased incidence of stroke compared to their counterpart without major depression. So again, we are not surely understand why the mechanism linking depression, diabetes, and cardiovascular morbidity and mortality, and possible, behavioral factors like smoking, less physical activity, poor drug adherence, poor self-care contribute, as well as some pathological. So I want to share with you this very nice meta-analysis recently published in Primary Care Diabetes because I'm the editor-in-chief of Primary Care Diabetes, and I have the pleasure to, select this article and then publish it. It's a meta-analysis including 26 randomized controlled trials, including over 4,000 people with diabetes, aiming to evaluate whether cognitive behavioral therapy is effective in people with diabetes and depression. And what they found is that cognitive behavioral therapy is efficacious in decreasing the depressive symptoms. So we can see the significant decrease in the depressive symptoms. However, there's no significant association between A1C changes for CBT. So here I want to share with you the research question come to my mind, and that's why I have the funding to conduct a new randomized controlled trial aiming to investigate the effects of cognitive behavioral therapy, insomnia for people with comorbid diabetes and insomnia. And I'm very grateful to the funding body for me to have the resources to conduct this trial. And this is a study flow. And basically, I recruit Chinese type 2 diabetes patient, older adults aged 60 years or above with insomnia as evidenced by insomnia severity index 14 or more. And I randomized eligible participants into intervention arm with CBTI, basically 6 weeks, once per week with 2 hours per section. And then the control group will have the same contact time with usual care, but then they won't have any CBTI. And I study them at 3 months, 6 months, 12 months. And just want to share with you the interim analysis that you can see the orange line represent the subjects randomized to the intervention with cognitive behavioral therapy for insomnia. And you can see the A1C reduction with a trend from 3 months, 6 months, but then, at 12 months, it has a rebound. So I think there's a kind of learning from this study design that we only have the intervention in the first 6 weeks, and then without any subsequent measure to engage the patients, the participants, and so we have a rebound at the end of 12 months. And so another slide to summarize. Indeed, this is going to be published in General Diabetes Investigation very soon online, and work with my collaborators from Copenhagen, Dr. Faden Mackles, and also psychologist Dr. Wing-Si Chen. And we summarize the evidence why there's a link between insufficient sleep, extended sleep, or circadian disruption like shift work and other sleep disorders like insomnia, sleep apnea. All these work also contribute to the etiology of diabetes and also increase the cardiovascular events and mortality. And indeed, there's a bidirectional relationship between sleep and diabetes. I mentioned about how sleep impact on glycemic control, but also in people with diabetes, they might have nocturia, that they wake up in the middle of the night to pass urine, that will interfere with the sleep, and also some of them may have complication like painful neuropathy. That pain is really a problem, because as you can see from this cartoon, when somebody got pain, that will actually cause anxiety, depression, and interrupt with the sleep, and that will result in all these associations. So I know I a bit overrun, and then this is the very last slide to summarize the message I want to convey to you. Number one, sleep problems, depression, and diabetes are all prevalent conditions, and they are interconnected. And sleep quantity, insufficient sleep or extended sleep, sleep quality, circadian disruption, sleep disorders like insomnia impact negatively on our energy metabolism. And there are data from systemic review of randomized controlled trials showing that cognitive behavioral therapy significantly reduced depressive symptoms in diabetes with comorbid depression. And I'm happy to share with you the interim analysis of RCT, from my team that suggests that CBTI result in a trend of A1C reduction, but then there's a rebound. And so I would like to end by acknowledging all my team members and collaborators, and also would like to cordially invite all of you to join the East Meets West Symposium to be held in Hong Kong, September 27 to 28. And for those who are interested, please hook on to our website or, scan the QR code, and then I look forward to welcome you in Hong Kong. Thank you very much for your kind attention. Thank you.
Oh, thank you very much, Alice. This is a very important topic, sleep and diabetes, and the consequence of lack of sleep and the depression. And one of the most important things that you mentioned, that not only the quantity of the sleep, but also the quality and the timing of the sleep. I think this is an issue can be overlooked by many, that sleep is just passing hours on the bed, but not. It must be at a time, at a good quality, and the consequence of cardiovascular and the deterioration of the diabetic complications and embarrassing the quality of life for our patient by lack of sleep deserve much attention. And we are eagering that this modality must be well assessed in the diabetes clinics, either in the hospitals or primary care setting, because this is a very important issue. Thank you again, and we are looking for more questions to come for discussion. Banshi?
Yes, Alice, one question is those who are taking sleeping medicine, will you put them on a condition, many of our geriatric patients, they are regularly on either anxiolytic drugs, or some of them are on even on lorazepam, some of them they use different type of drugs, or even common things also for sleep. So do you think they are under the conditions, will you call them sleep deprived, or will they have that close linkage? Is there any study, those who are on sleeping medicine with the diabetes and distress?
Thank you very much for your question. In fact, I don't have the chance to show the slide about the review article I mentioned published in Diabetologia. Indeed, for insomnia, the first line therapy should be cognitive behavioral therapy. And indeed, one of my MPhil students summarized the evidence that many sleeping medications have negative effect on the glycemic control, and also the issue of dependence. And so therefore, as I mentioned, I declare I'm a strong supporter of lifestyle therapy. And I think there's something under-recognized for the non-pharmacological therapy. I know many a time in busy clinic, doctors prescribe a pill and then let the patient sleep. But then that's actually not something good for the patient in long run. So so I'm not sure I answer your questions, but then I think medicine in terms of the sleeping pills like the GABA pathway, etc. They have side effect that we need to bear in mind.
Thank you. Thank you, Alice.
Can I ask you a question, please, Alice, regarding the shift work?
Sorry?
Regarding the shift work here, is it difference between the permanent shift worker schedule and the temporary one regarding the consequence of deprivation of sleep or altering the time of sleep and the quality?
Alice, his question is related to shift workers because their sleep patterns keep on changing. Will they have effect on their diabetes?
So I'm not sure I get your question correct about the sleep pattern, right? About sleep. You mean the sleep cycle?
Yeah, yes, and for the shift workers,
chronotype.
is the duration will differ. Either it is a temporary 1 or twice per week, or permanent for months, changing the schedule of the shift workers.
I got your question. I think you're talking about a short term, because usually we define, I show you the 3 Ps. So short term should be okay, but then don't go into chronic into maladaptive behavior, because I think there's a lot of data that in the sleep lab, for example, by Eva Van Carter in University of Chicago, who is the pioneer to do a lot of study. Terms, we actually, demonstrate increase in insulin resistance, glucose metabolism worse. But then only in long term that we found the consequence in terms of the cardiovascular disease, etc. So I believe that, and also for insomnia, the definition is that, more than 3 times per week in a month. So if you have the problem for short term, don't let yourself run to long term in chronic. So an important thing is, maintain a good habit, and also include kind of regularity is also important, and then don't let yourself run in chronic. So I think many of us like traveling across time zone or on call duty, whatever, we can have a very short period. But then our, just take an example, we pull a rubber band, don't break it, because we need to kind of relax and then let it have a, the hormonal system go to relax. So I hope the message to our patient is that don't, stress yourself too much. And I have my data, I mean, the data from my group and also others to demonstrate that sleep compensation is also important. So for example, if you kind of need some commitment that for usually slept already, but then I need to, for commitment, I need to shorten my sleep. But then tomorrow that I need to go back to my, routine with the regularity. And then so some, people in weekend, they need to have some sleep compensation. So I didn't have detail go into my database and also from other researcher. For example, if you can have sleep compensation in the weekend about 1 hour, this is the most optimal for your glycemic control and glucose metabolism. So when you're stressed, for a short period of time, but then don't make it become something chronic. And then let yourself, system revert to, adjust to a normal. And then sleep compensation is really something important.
Yes,
Thank you,
but the sleep
Alice.
compensation at the natural time of sleep or at any time?
I think the important thing is regularity. So for example, you go to a party and then whatever, and then don't change the cycle because the chronotype is also important. So for example, when we conduct the cognitive behavioral therapy or the sleep hygiene education, we need the patient subject to have a sleep diary, record clearly what their usual habit. And then when they kind of, for whatever reason, they can sleep and then they don't suddenly sleep in the afternoon and then change all the circadian rhythm. Because everybody got a clock in the organ. So we need to adjust back to the usual clock.
Thank you.
Yes.
Thank you, Alice.
What is
It
your
was wonderful.
last question?
And no, sorry, Vishwajit, because we are already late. I'm sorry, Meshwa. Thank you very much once again for wonderful
Okay.
Come to East Meets
moderating the
West.
session.
Okay.
And Alice is already in middle of the night, and I'm sure today she's going to have sleep deprivation also because it's
Yeah.
already 12 o'clock for her also. So thank you once again, Alice, and thank you all the
Thank
speakers.
you.
And Meshwa, once again, thank you for nicely
Yes,
have
thank you.
moderated it. So thank you very
Thank
much. Now, without much wasting the time, because we have now less than half an hour for a discussion, for a panel discussion. It's very important panel discussion. I will first request everyone to open their video. So, it is getting recorded and then everyone can, we can see that everyone can see their faces also. The delegates would like to see your faces also. Abdul, Bashir, Shashank is already there, Madhu, even Ashraf, for everyone. And this is very important discussion which we are going to have. That postprandial hyperglycemia in Asia is really a very distinct metabolic challenge. As already Dr. Bashir had talked in his in his opening remark, that 80% of diabetes is in Asia. And one of the important reasons for that to have diabetes in our country so high is probably the post-meal hyperglycemia. We have three important persons who will be joining as a panelist. We have Professor Dr. Shashank Joshi, who has worked in post-meal hyperglycemia. His starch study is very famous in India. He's a MD, DM consultant endocrinologist. He's affiliated with a Joshi clinic. He's a senior endocrinologist from Lilavati Hospital. He's been given Padma Shri from Government of India. Recently, he has given talk from American Association of Clinical Endocrinology on important topics on obesity. He is a very regular speaker in American College of Endocrinology. He's a past India chapter. He's the immediate past chair of IDF Southeast Asia. He's a past president of our RSSDI and Endocrine Society of India. And he's currently a patron for RSSDI. We have a very eminent lady from Dr. Umaira. She's from based at UAE, United Arab Emirates. She is a consultant diabetes and endocrinology from Emirate Health Service. She is trained in UK. She is CCT, UK, MRCP, Endo and Maternal Medicine, King's College, UK. She is will be from UAE, and then we were having one from Taiwan. So unluckily, just I got the message before a few hours that she is not able to, he's not able to join from Taiwan. So our idea was that this post-meal hyperglycemia, as it's a condition which is like from India or from Pakistan, this is like Indian subcontinent, then Middle East, and then someone from East, they should join for this very important discussion. Now, to have this panel complete, I will request our Professor Dr. Abdul Bashir, who is currently President of Diabetes Asia, and he's also Director of Indus Institute of Diabetes and Endocrinology from Pakistan, to join this panel also. And we will request others to also have, if they have any question, Dr. Nihal, Dr. Mohammed Sandeep, and Dr. Meshwa and Dr. Vishwajit from Bangladesh, who is currently Secretary for Diabetes Asia. To start with, first talk with Dr. Shashank, that you had done the STARS study in India and that became very, very popular to show that we Indians all the time eat the carbs, and it's our post-meal hyperglycemia is a major challenge. I remember long back, IDF also had come out with a guideline which was only talking about the managing postprandial hyperglycemia and PPG management. That was a challenge. And we know that Western people, even ADA ESD guideline, we had never seen even talking about the post-meal management. Now we have a lot of medication to talk about, but we start with you, the STARS study. Would you like to talk more about it? And then we will take the discussion further. Over to Dr. Shashank.
Thank you, Bansi, and thank you, Dr. Abdul Basit, and everybody, Mesbah, and all my colleagues from Asia Pacific. I think three things are very important. Worldwide, there was a very popular physiologist from France, Professor Louis Monnier, and he felt that if your A1C is above 8.5, it is all fasting. Below 8.5, it is all postprandial. But because we live in this part of subcontinent, which is Middle East and Africa and Asia Pacific, we predominantly eat carbs and fats, and we eat very less protein. That is our main diet. We tend to eat very fast, and we have a very fast, rapid increase postprandially, 30 minutes, 60 minutes, 90 minutes, 120 minutes, a very rapid spike of glucose. And our first phase of insulin secretion gets lost very early in the development of prediabetes and type 2 diabetes. Unfortunately, the Western world has gone into A1C, and they have gone into fasting, and they abandoned the entire postprandial concept. So when we did a pan-India study, which is a STARS study, we observed that across India, whatever may be the meal, people eat a lot of carbs and fats, and they eat less proteins, number one. And number two, the fasting glucose often remains normal. It may be, 90, 100, 110. Prandial glucose is around 180 to 260, and the A1Cs are all around 8, 8.5. That's the audit which we found. And that is something which is very distressful, which means that if you observe a normal fasting with a high A1C, it is predominantly driven by the prandial glucose. And if you see the entire cardio-metabolic spectrum, the postprandial glucose drives the postprandial lipid wave. And that eventually leads to atheroma and disruption of plaques and thrombosis. And that is why we see the cardiac complications in our part of the world, which are very high. And therefore, it is very important to nip the prandial glucose spike. And I think simple things like what we observe from STARS study, eating slowly, eating on time, using starch blockers like alpha-glucosidase inhibitors. Now, if you see the worldwide guidelines, ADA, ESD particularly, they don't use alpha-glucosidase inhibitors. But if you see China, Japan, India, Korea, and Asia, we do use alpha-glucosidase inhibitors because it blunts the postprandial spike. Of course, there are many other agents which blunt it also, and we also use short-acting insulins. So I think the importance of 1 hour prandial glucose, 2 hours prandial glucose is very useful. And I think it's important for us to recognize it that from our part of the world, we need to generate more science and data like STARS data across the entire DASG region. And we need to persist with simple guidance, both from lifestyle and therapeutic perspective, that prandial glucose, and that's why I have to congratulate IDF that they came out with this 1 hour glucose guideline recently, because Professor Antonio Cirolio also has been a firm believer, and both Professor Basit and Sabu, you have been, and even Biswajit and everybody around here, they have firmly believed that we do tend to have a problem after glucose. The area under the curve is the key. And whether it is 30 minutes, 90 minutes, 60 minutes, 120 minutes is a debate. WHO arbitrarily fixed this value as 2 hours. But this fixation, which is arbitrary, needs validation in our context. And probably the 1 hour glucose value and the area under the curve of 1 hour and 90 minutes probably is much more robust in terms of its reproducibility, in terms of its receptor operated curve, or ROC as it is called, in terms of its validity. And therefore, and now it has become more easy to estimate prandial glucose with the advent of CGM. Because of the CGM, we are now able to see the glycemic variability. And due to the availability of CGM, we are able to go into time in range and time in, high glucose and low
So
glucose
that
much
we will
better.
take later on the CGM, how
Yeah,
to diagnose it.
sure.
So,
So I think I'll
Umaira,
stop
you
here.
must be
Yeah.
also seeing the similar type of situation in UAE where you practice, and you've been trained in UK where you must have seen many South Asians. So you must have seen distinctly the difference between the white population and the South Asians to whom you have seen in UK and in UAE also, because it's a condition, country where a lot of even British people are also Caucasians are also staying in Dubai. So how distinctly you see and what the clinical consequences of post-meal hyperglycemia in a clinical practice?
Thank you, Dr. Bansi, for the kind invite, and also DSG for the kind invite as a panel. And it is really an important topic and a good question, because I have seen it's been lucky to see both in UK as well as in UAE. And not to forget, we have 18% expats are in UAE. And these are expats are mostly are Asians. And they do not forget, because our staple of food is still the rice. And the staple of food rice, and we still tend to eat the whole glycemic load. The whole glycemic load is a lot. And this has affected a lot in our population. We have seen how we have seen either it's UK Asians or in UAE, they follow the same route. They have the glycemic load. The food love is there. It's like because if we have festivities, we still celebrate everything over here. And what we see is they tend to have a food storm. And to add into Dr. Shashank Joshi, she said that in Asian, which we have studies have also found that there is a increased gastric emptying, and there is increased absorption of the carbohydrates and this glycemic load. So what we have seen that this is the particular problem, and I tend to see up in all my patients over here the same, and what they come up with that is like, it's okay, doctor, I just had food and that's why my blood glucose is so high. It's all right, it's fine, totally fine. I had my carbs and I had my particular whatever the rice food it is, and that's why it's high. So the concept that, the time in range, as we said, the concept that we have to be below certain range, which have the IDF and all the guidelines have recommended, is still lagging in our population, whether it was in my UK Asian, whether it is in my UAE Asian population.
Great. So, Dr. Bashir, what are the different prandial regulators which are available in Pakistan? I mean, this is a concept which I think post-meal hyperglycemia is not a new concept, as we know that Caucasians never used to do for their patient the post-meal glucose level. They used to measure only the fasting and then HbA1c. But we, in our continent, in Asia particularly, we always has to have our patient fasting and post-meal glucose level both. And now we have a lot of prandial regulators, but what you use, because you have a more than 40 years of experience of treating type diabetes patient, what different medication you had used to treat from lifestyle modification to the newer agent for prandial regulation? Unmute, sir. Unmute.
Thank you for the
Yes.
question, Banshi. I must admit that we have to address both insulin resistance and insulin deficiency in our parts of the world. And yes, as Shashank was saying, we may see people who are having normalish fasting and highish postprandial, but our usually the sequence is high fasting, high postprandial, high HbA1c. That's our usual norm. So we have to rely on all kind of medications which are both secretagogues and then those who are postprandial regulators. What we face a dilemma is, for example, when we put people on short-acting insulins or postprandial regulators, they gain weight, and weight again is making them more insulin resistant. So my tendency is to use mixture of both SGLT2, like for example, metformin, then a mild sulfonylurea. I must admit that Shashank said about alpha glucosidase inhibitors, which are, I know, being used still in China, India, and Japan. In Pakistan, we are now hardly using them. Now, the reason may be simply that we were not able to have good results with them initially when it was launched, or we, as I said, that we were not singly targeting the postprandial hyperglycemia, or you can say the side effect of having belching and bloating, etc. And because we are used to heavy meals and heavy carb meals, and as Umaira said about rice, we are also wheat eaters and very heavy meal eaters. So we have never been able to, for the last 30 years or 25 years, not use alpha glucosidase inhibitors to that extent, as Shashank Joshi has just said. So this is my reply, a simple reply to that. We still are using mixed bag of medicines, targeting both insulin resistance and insulin deficiency, targeting both fasting and postprandial at the same time. Thank
Dr.
you.
Nihal, if you are there, Dr. Nihal. Dr. Nihal, are you there?
Bansi.
Sorry. So, yes, you were saying, Beshwaji, something?
And in reply to Professor Abdul Basi, in our clinical practice, we use the alpha glucosidase inhibitor and also the non-sulfonyluretic glycinate, ripaglinides, and we have get the good result still now, in spite of the some of the GIT upset, but still working, and it is available in Bangladesh.
So you use the glinides and alpha glucosidase inhibitor very often to control the post-meal hyperglycemia. So Shashank, to you, one question which is very popular in India is a pre-mix insulin. And as Dr. Bashir was talking about that we have insulin deficiency, we have both the conditions, fasting hyperglycemia, post-meal hyperglycemia, and HbA1c, all three are very high. And sometimes we use, and it had become a market of premix in India particularly. So we started using, because we wanted to control the post-meal as well as fasting, both by using the premix insulin. Now in current situation, when we have a lot of prandial regulators, like, the GLP also very, nicely can contain, they can control the post-meal hyperglycemia, even DPP4, SGLT2, the glycemic excursion can be significantly reduced, or even the prandial regulator like the medication like glinides or alpha glucosidase inhibitor or short-acting insulin analog, they all can take care of this. So still where you find that premix insulin is still a good choice for controlling the fasting and post-meal both, or should we change it to the basal bolus or only putting them on a basal and GLP-1? Where is you think that where the premix insulin will work in this situation?
Premixed insulins again are part of Asia, and mainly because of our prandial spikes. I completely agree with Professor Abdul Basit. Most of the patients we see are fasting of 200, PP of 300, and A1C of 9. That is something which we see every day. Just now also I'm in my clinic when I'm talking, and I just saw the patient as you were talking actually with the same numbers which you are echoing. So that part I totally agree. The premix insulins traditionally from a pure pharmacology and physiology point of view is not perfect, Like for type 1 diabetes, it is basal bolus. That is a standard of care. But, for primary care in China and India, we came out with guidelines, and I have to recognize Professor Linong Ji, who just had a publication yesterday in New England Journal on a new GLP-1 analog. But they were the first people in 2008 to come out with a premix guideline in China. 2009, we got out a guideline of premix insulin in India. And across the world, people use premix as a more of a convenience, that they have 2 meals or 3 meals. And with that meal, instead of using 2 injections or 3 injections, rather than using 4 or 5 injections. That is the compromise we were doing. The problem with the premix insulin is it has to be given at the same time. The carb to fat ratio has to be same. The meal has to be identical. The carb content and the caloric content of the meal has to be identical. And you have to be very regimented and rigid on the diet. So it is not perfect, but it gets you an average. It is able to get you a dent on the overall glycemic control. So that part is there. In fact, Novo went one step further and they did Rhizodec. Sanofi went one step further and they went into Soliqua, which actually got the basal to control fasting, and then they use the short-acting GLP-1 to control the PP. And that's also in the guideline now. It's called as a fixed ratio. And I think it basically is addressing this prandial glucose curve. So the prandial glucose curve, because of 3 problems. Number 1, too much of carbs. Number 2, too less proteins. And number 3, eating very fast. I think that's one thing which we have to recognize in our part of the world is we tend to talk fast and eat fast. I think Asians in general, all of us, whether you are from Middle East or Asia, we think fast, eat fast, and eat too much. That's a problem which we have. And we have to You may still think fast, but if you have to eat slowly, eat less, and eat less carbs and fats. That's the key.
Very nicely summarized by Dr.
But is
Shashank.
there any genetic,
Can,
predispositions? Shashank, just
Genetic, what is you are asking?
say
Vishwajit?
genetic link.
Genetic link for the post-meal hyperglycemia, you are
Indian,
saying?
South Asian.
So maybe one is thin fat Indian, maybe in a
I'm
concept.
not so sure,
We have more of a
Vishwajit, if we have a
preparation.
genetic link. I'm
It's
not so
a
sure
carb.
if there's a genetic link. It is more of the environment. I think type 2
Yes,
diabetes is a
doctor.
polygenic disease. And I'm not so sure whether we have a genetic link to the insulin excursions. I think it's more of a lifestyle. And I think it's more of a lifestyle character.
Yes.
I'm not aware of any genomic studies, but I would like to be educated if there are.
to add in,
Umera, I just
Yeah,
want to
Umera.
ask you one question.
okay.
You know,
So,
the using continuous glucose monitoring in type 2 diabetes is still evolving guidelines. And as you have practiced in UK and UAE, which is a rich country where people can afford to have, but we are also having the other Asian countries where somewhere it is not available. And some places, even it is available, we can't use for each and every patient. So how often you find that using CGM and then getting this, post-meal hyperglycemia peak or mean excursion of glycemic excursion, mean amplitude of glycemic excursion, which you can see on this or the glycemic variability seeing on CGM, and that will decide your therapy also. I mean, using and then that will convince the patient for lifestyle modification or giving a one particular type of therapy. How useful in your clinical practice using CGM? And then I'll be asking Vishwajit and Dr. Abdul Bashir that we are not using so often CGM, how we manage this post-meal hyperglycemia by using self-monitoring of blood glucose. Over to Mera.
thank you, Dr. Bansi. It was a really good question. If you ask me about UK, it's an NHS system. So in type 2 diabetes, it's very difficult to get us the funding for type 2 really to get if it's really, really difficult. It's very, very
And what
difficult.
about the UAE?
But UAE, yes, we have two systems. One is Emirates Health Services, where we are in a government sector where everything is free for our patients. So if they are on just a basal insulin, or if they don't like needles, or if I want to give a trial, I can give them CGM. But if it's a private sector, it's going to be really difficult, like the rest of the insurance based in UAE, to get them on the CGM. But since I do wholly an EHS, which is a quite...
Sorry, I think she disconnected. So Dr. Abdul Bashir, how often you use CGM in your clinical practice or in Pakistan? What is the usage? But if it is not there, how often you use the self-monitoring of blood glucose just to understand only the post-meal hyperglycemia? And that too, particularly, I want to understand how often your patients will agree to do their post-dinner sugar, which is again a very difficult, because many of our patients, they actually tend to have very late dinner and then they will not do the post-dinner glucose. It's mostly post-breakfast or post-lunch only. So that's how you are going to do it.
Right. Banshi, before answering your question, I think I'll have to agree with each word Shashank used about pre-mixed insulins and the dilemma with pre-mixed insulins. In our experience, what we have started to do is to put patients on basal insulin and then for postprandial supplement with them with the orals. So that's how we avoid pre-mixed. And we are firm believer that pre-mixed in our parts of the world where we are dealing with central obesities and insulin resistance is at times not doing the good favor with our patients. But nevertheless, still as Shashank said very clearly, for convenience, for compromise, for ease, we are using pre-mixed insulins. Now coming to your question of CGM used in Pakistan, it's not very well accepted and prevalent right now because of cost, because of other multiple factors. So we're still relying on SMBGs. Now coming to blood glucose monitoring, how often do we get good going results with postprandial? As you said rightly, yes, we can at times get post breakfast or post lunch, but what is then post dinner? And honestly speaking, what we have done is, when initially or good 20 years ago, we used to give a 7-point profile to the patient. Seventh one was bedtime. So what we say is the post dinner is basically their bedtime. So either you label it bedtime or you label it a post dinner. But yes, it's a
But
dilemma.
still, you
And
know, sometimes the people
this,
eat at 9 p.m. and they go and sleep at 9:30. Or
that's right.
sometimes they take their
This,
dinner at 10 o'clock and 10:30 they are in bed. So it's
exactly.
really difficult for them.
So it's very difficult and it's not practical. And as Shashank was saying, at times we are now starting to rely on 1 hour post meal rather than 2 hour post meal. We want to target their glucoses, which is high off the sky anyway, post 1 hour, post 2 hours. But yes, as CGMs and Libre, etc., shall be more prevalent in our parts of the world, unfortunately, it is not as highly recommended as it should be. That's our limitation.
Great.
Thank you.
So Umera, you were disconnected. You please unmute yourself. Unmute first. Umera, unmute and continue your answer. Umera, you are muted. Hello.
Hello? Sorry.
Yes,
Can you hear me?
go on,
Can you hear me
Umera.
now?
Yes, we can hear you,
Oh,
Umera.
I'm so
Please.
sorry because
I
I'm
hear
so
you.
sorry. This technical error. Sorry. Okay. So we're talking, I'm really
Okay.
sorry for this. The CGM we said, and as in UAE, so as I said, we do get the opportunities and in the Emirates Health Services where we do use the CGM, and it is quite widely used for type 2 diabetes patients, whether I want to check the profile for a short while, whether if they're on a basal insulin or they're needle phobic, or I want to just check the profile. Now, how does it help in my practice or my colleagues' practice? As we say, again, there's a huge glycemic load, and the patients, when they actually get a real time shock for themselves to see that when they put the data and they see that they get the high blood glucose and their maximum, most of the time they are postprandial, their highs. So it does change our practice of clinical management hugely. And how does that affect that? What in my practice, what I tend to say them that, we are having all the wheat and the rice and all that. So just what we change, and we have seen the difference, the sequencing of the meal times, what to take first. So they come to me, they show me that, we take a detailed history, like what they've been eating, what was their schedule. I actually, besides my dietitian is on board there with us in the same one-stop clinic, I tend to take history myself and check with the patient, what did she eat in all her, or they eat in the meals all. And they see the difference that most of them who listen do understand, and they do really want to do reflection management. So they go and change the sequencing of the meals. Instead of starting the carbohydrate or the rice first, have protein first, then have your vegetables, and then you have your rice, which you want, along with the portion control. That tends to see the glycemic excursion, which we see postprandial, much controlled in this population. And this we have seen quite a lot of studies doing on one of the study we are doing with the dietitian on this point, to see with the postprandial how we can sequencing of the meal, if we do, how we can really manage them. And also, as we see that we Asians tend to have our food and immediately said, oh God, the best thing done of the day. No, so that's what we discussed, and lots of studies have shown that, which I see, since I do antenatal diabetes a lot, and we all have see that in GDM patients. And now we have seen in my typical these patients, after seeing the CGM profile, that when they do a 15 minutes walk immediately after their food, a brisk walk, we see that the post meal excursions are better. And the patient actually come to me and show me that, look at my profile, look, it's so better. And of course, those who want to, they will not bring their profile to me or not link it to me. But I mean, most of the patients actually really work on it. And this is something has really helped in combination along with our meal sequencing, walk 15 minutes, which I see most in GDM, but also my type 2 diabetes patients not sitting on the couch immediately after the food, or this is the best day after having your food. And the third thing which I see is then that helps me in showing that, because we do have a lot of tirzepatide and, as we say, Manjaro, GLP-1 and GIP, and this has shown that the greater postprandial, as well as both fasting, postprandial hyperglycemia has been managed on it with 80 to 80 milligram per deciliter. And also weight management. So we tend to use that with basal insulin, and they later on add insulin analogs, because we don't use acarbo still here. We don't have it in the short secretagogues. And premix also is less in UAE compared to other places.
But very rightly, you had said two very important lifestyle modification, the meal sequencing. And you know, those who does not know well Hindi, but I can tell in Hindi, in our ancestor, we always say dal bhat or dal chawal or dal roti. So it is the first protein and then followed by carbs. It is not other way around. It is not roti dal or it is not the chawal dal. It is always dal chawal or it is always dal roti. So, you know, the protein first is in a concept, which is there in our Indian subcontinent. And I'm sure many of you must be doing also in our clinical practice. And we also explain our patient that always take first protein followed by this, and very right advice, which you had said that post meal, a brisk walk will also help them for this glycemic excursion to go down. Vishwajit, you want to add anything in this, the similar type of situation? Because in east part of India or in Bangladesh, they tend to eat more like meat or the fish, or they are more fish eaters. So do you find still the rice is picking up or the post meal sugar is very, very high? So how you manage their sugar by just lifestyle modification? What you will say that first you eat this
No,
concept of more
we follow
protein.
we follow the the plate model. The half of the portion is the come from the the vegetables, any type of the vegetables, and then the 1/4 from the protein and
So more fibers first, you will say.
yes, that is the way. And I also believe the good counseling is important here. I totally agree with Abdul Basit sir, as because CGM is not available or not popular yet, considering the
Cost may be the challenge.
cost is the challenge. And the SMBG, like the after dinner, is a very
challenging situation.
challenging, but still we need the good counseling. And finally, I agree with we should follow and we should include the nutritionist, because without the nutrition counseling you cannot do. And I rightly agree with the Omega, as because we did some good randomized control trial, the GDM, and in GDM we use the postprandial walking 5 to 10 minutes for the controlling the postprandial in the glucose in the GDM patients. And I believe we should also include this in the things in the maintaining in the postprandial blood sugar in the type 2 diabetes.
Thank you, Vishwajit. So the last question to Shashank, because we have to wrap up also, it's already late, and we have 1,369 delegate participants from different parts of the Asia who joined today. So Shashank, it's very important, as you had already talked about, that IDF had also come out with a post-meal guideline for 1 hour post 1 hour meal. But do you think that this part of the world where 2/3 of diabetes are there, but at the same time 2/3 of diabetic patients are not under good control, is it the post-meal hyperglycemia is a major challenge? Well, every day their diet is different. Even if you change their therapy, still they keep on eating sometime, and their sugar, if you do their CGM, you will find multiple times their sugar or peak are there. And at the end of the day, the average HbA1c never comes less than 8.5 or 8. Even you do the best. If you just try to get their fasting, they will get less than 130 H per EDA guideline, that fasting less than 130 your target, but then average HbA1c never comes less than 8.5. So what you think that, this post-meal hyperglycemia and the concept of 1 hour post-meal glucose level, what is your message for this, for all the delegates who are there, and what they should do in their clinical practice to achieve a tight control? Because I think it's a post-meal hyperglycemia is a real challenge for us.
Bansi, I completely agree with you. And just to highlight what Biswajit was saying, coastal part of fish eating, rice eating world will have carbs. But remember, both rice and wheat, both are carbs. So, we need to not ignore that fact also. And we have to mix it with pulses, and we have to precede it with proteins. So if we precede it with proteins and the way we sequence our food, it's equally important. So I agree with Dr. Abdul Basit, Biswajit, and Umera that it's important to do a lot of counseling here. And that's the key. Postprandial glucose, this part of the world, from Suez Canal to China, more than half a day they spend in the prandial state, postprandial state. And we have now good insight, both clinically, anecdotally, and evidence-wise, to suggest that more than 12 hours, people are in the prandial glucose state. So what Bansi you are saying, we are able to see it because we are doing CGMs routinely now. You see, almost every person who's living, because I work in remission space, I do CGMs for everybody in type 2 space. And because of that, we have an access now to see these glucose under the curves. And we are able to see that the time in range is not in range. And therefore, I feel that we should highlight this guidance, both prandial glucose control and 1 hour glucose control, because we are from this part of the Suez Canal. And we need to ensure that we need to get better glucose control, because it is not just A1C which is important. I think even with A1C having less glycemic variability, having better prandial glucose regulation will lead to lesser complications. And there is data. Now, most of that data has not been intervention. Most of the data of prandial glucose has been linked from a public health standpoint to cardiovascular events, right from DECODE study, etc. Now we have data with interventional agents, and we really need to document and do research that after we intervene prandial glucose, do we have better cardiovascular outcomes? Unfortunately, Asia-specific CV outcome data has been lacking. We have piggybacked on the global data, and we have tried to extrapolate it to us. So I think it's important that we do loco-regional Asia-Pacific trials and generate some good science and evidence in this space. But I fully endorse what you are saying. That is important. And I'm very happy that you at DASG, and I have to congratulate Dr. Basit and the entire team, Biswajit and everybody here, that we decided to focus on this very important, pertinent issue, which is relevant to our population. And therefore, it is important that we need to address it through research, through public health, through better awareness. And I think it is an order of the day.
Great. Meshwar, do you have the similar situation in Egypt? Abdullah is also there. Nihal, if you are there, if you want to make any comment.
Yes, actually, most of the time, as Shashan said, the postprandial hyperglycemia, and due to the challenge of CGM is not available for wide scale, and we try to check this in the 7 points and then concentrate on the meal that is the largest one to be checked regularly. Maybe dinner is not as much as in India and late in India and Bangladesh and Pakistan, but the lunch is the main. Maybe late lunch at 5 o'clock or end of the day, but not at 12 o'clock. So we can check it specifically when we found that this is the most prandial time for hyperglycemia.
Thank you. Dr. Nihal, I mean, in between, I asked you also, Dr. Nihal Thomas. So one important question, you know, that postprandial regulator, the GLP-1 analog are also very useful to control the post-meal hyperglycemia. We also know that post-meal hyperglycemia is directly connected or correlated with increasing atherogenesis. So do you think that using GLP-1, which is not only going to have a better control of post-meal hyperglycemia, but that could be one of the reasons that better control of post-meal hyperglycemia by GLP-1 is the reason for a anti-atherogenic effect of GLP-1, and it is giving you a good cardiovascular outcome? It can be, I mean, just because we don't have the direct data, but indirectly, can you think of it that way? Dr. Nihal.
So I think it probably works both ways, and I don't think it's exclusively postprandial. I certainly think that the postprandial effect is important, but I think I think it's a global effect, both in the fasting as well as in the postprandial phase. Just to add to what the other thing is, which I think is very key to the initial foundational aspect, particularly in the patients who develop diabetes at a later onset, the repurposing of meals timings, which I think Dr. Kamal is actually talking about late meals, etc., which is the repurposing of meals at an early phase in the occurrence of type 2 diabetes is so very important. It's difficult to do it after 20 years of having diabetes after the age of 65 or 70. but at the early onset, at say 45 or 50, repurposing and timings of meals is so important. And that's when also you can have a significant impact in terms of targeting postprandial hypoglycemia.
Thank you, Nia.
But
Now,
I have a
Vishwajit,
question.
I mean,
I'll say.
we can close it and you have to give the vote of thanks finally.
But before that, I have a question I have the, some question to all of you. How do you control the year-long food and fruits festival?
Food storm. That's the love of our nation, our festivities and everything,
what
and
the
that
culture
results,
is.
yeah, the culture, and in that love is then transformed into this food storm, So
Yeah.
That is the reason why we have high epidemic of diabetes also.
Okay.
So with this, I thank everyone, and now I request Dr. Vishwajit, who is currently the Secretary for Diabetes Asia, for proposed vote of thanks for today's webinar, and I will request all those who are registered for today and tomorrow DSG webinar, please join tomorrow. I am thankful to every delegate, each and everyone who could join from different parts of the Asia, particularly those who have joined from East Asia, because for them it is like middle of the night. It's almost 1 o'clock or 12 o'clock. So with this,
Yes,
Dr. Vishwajit, over to you.
yes, Banshi, I am in China, Banshi. I am in Beijing.
Oh, you are visiting? Okay.
Yes, I, I met Lennon today, and we have a fancy meeting. Yes, so it is almost 12 o'clock now here.
Yes, yes. So I know that Taiwan, I got the call. I got from Hong Kong. So they are almost in Japan. They could not join because of their level. Over to Vishwajit.
Okay. So on behalf of the DSG team, I would like to give our sincere thanks to Professor Peter Schwartz, President IDF, and Dr. Abdul Basit, President DSG, for their opening remarks. Thanks to Dr. Mesbah for chairing today's session. And thanks to all our speakers for their impactful presentation. Thanks to all our panelists for their useful remarks. And thanks to Dr. Bansi for your moderation. And we are grateful to Roche for their support. And top of all of these, thanks to all of our participants for their kind presence. And before signing off, I welcome all of you for your tomorrow's participations.
Thank you. And thanks the RX event for wonderfully, giving us the platform where we are all joining online. With this, I thank to everyone, each one of you who are here, and all those delegates also and participants. With this, good night. See you tomorrow again the same time. We will have those who are here today for as a faculty, please join tomorrow again for more discussion. Thank you.
Okay, thank you.
Bye-bye.
Thank you, Banshi.
Bye.
Thank you, Banshi, and good luck for the Diabetes in Asia Study Group. And
Thank
this
you.
is a very, very good initiative. And I always called you the dynamic kid, and now you are the dynamic boss, not dynamic kid. And I am happy to listen to Bishwajit, Shashan, Basit, and Riaz, and Nihal, and Alice, and
Meshma, don't forget the young girl,
yes,
Vera.
this is our flower for all.
So she will be now very